One, this is Dr. Ashraf Al-Tayyar, consultant of acute and critical care medicine, currently in UK. And I have the pleasure to moderate this very important point of care ultrasound webinar, particularly for emergency. So this is part of the activities of the point of care in emergency series of webinars that we are planning to do and planning to be covering the interesting and commonly seen problems in emergency department. Everyone knows and convinced that point of care ultrasonography in acute care setting in general, this is either in emergency department or in ICU or in OR, wherever is acutely ill patients are there, you find a great job for and a great opportunity for the point of care ultrasound to help in these matters, the management of acutely ill patients. It's my great honor and pleasure to co-moderate this session with Dr. Salah Imtiaz from Palestine. And Dr. Salah is well-known in Palestine for emergency, and he is the leader of the Emergency Society in Palestine. We are missing tonight to have Dr. Liqa Rafi because of personal commitments, wish to have her in the next activities. And I'm very proud and honored to also have Dr. Surgery Seniz from Bureau for the first time to be with us. We are very happy to have you, Dr. Surgery, and hopefully I'm pronouncing your name rightly. It's a great honor as well to have two of the eminent speakers in point of care ultrasonography in emergency with a great activities and interest in point of care ultrasound. From Egypt, Dr. Muna Surur from Alexandria University, where I learned, and Dr. Omar Jaradat from Turkey, and both of them, they're gonna talk about very important and very interesting two topics in emergency. One of them is POCUS in pediatric emergencies, and this will be handled by Dr. Muna Surur. And the other one is very interesting also, soft tissue infections by Dr. Omar Jaradat. This is the timetable of tonight. I'm going to give you a brief introduction to the second module of point of care online program. And the second module tonight will be announced for the ED section of this point of care ultrasonography 1-year fellowship program. We already finished the first module, which was basic for both arms, the critical care and emergency. And the second module will start soon. I'm going to tell you when, within a few minutes. This will be followed by a presentation by Dr. Muna Surur for 20 minutes, and another presentation by Dr. Omar to be finished 5 minutes to 7. And then we're going to have a discussion at the end of this webinar. You please direct your question either to Dr. Muna or to Dr. Omar or to myself within the last 15 minutes of the meeting. Without any further ado, let me give you just updates about what we're going to have. And we are inviting all of you to register in the coming second module of point of care ultrasound in acute care setting, the ED section, the emergency point of care ultrasonography. As you know, the program started on last June 30, and we are about to finish in December the first module, which was basic knowledge of point of care ultrasonography that of interest, we called it common pathway for everyone working in acute illness or with acutely ill patients. Then the section of the advanced module for emergency will be academically directed by Dr. one of our great friends, Dr. Wissam Ibrahim, a professor of emergency medicine, visiting professor now in United States, with a lot of good names, with good experience in teaching the emergency and particularly the point of care ultrasonography in emergency. And if you wish to know the details of this program and how to register, kindly visit this website, wiccem.org, POCUS Fellowship in Acute Care Setting, and then choose to go. While you scroll down, you will see the ED section. What you are expecting to see in this module, as in the basic common pathway module, that every week you'll be learning a topic with a presentation, journal club related to this, and the journal club will be a selected paper followed by 10 questions to answer your understanding of this journal. And every journal is pertaining to the particular topic assigned to this week. Then you're going to have a clinical case scenario of the common scenarios you see in ED, followed by 10 questions. You will have the opportunity to meet the faculty every 4 weeks. The first week will be live webinar, where the fellows will meet the faculty, ask their questions, bring their cases, or we bring them our cases. And every week we have every live webinar week, we'll have a couple of questions to test your understanding of the previous week. The fellows have a very well-known pathway to reach the program director and the faculties and to come in touch with us, discussing their cases, answering their questions all over 24 hours 7, almost 24 hours 7. Through the WhatsApp group, will be created a WhatsApp group for the fellows of ED section. Through the email to Dr. Wissam Ibrahim, to myself, to Habiba, and Habiba is one of the very active part of the ICOM e-learning group with Nurhan and many other personnel who are very active, very committed to answer questions related to the platform. Platform is very well designed, very easy to use, and you're going to see all the materials in the platform. As I mentioned, the academic director is Dr. Wissam Ibrahim, and you can easily catch his contact details very easily. Again, go to WICCEM, the umbrella of all of these activities, the World Institution of Critical Care and the Emergency, and you just visit this web page and you see the ED pathway with everything you wish to know about the program and who is teaching the program. The materials are here, the topics, they are all interesting for everyone working in emergency. Dyspnea in ER, shock in ER, obstetric emergencies, very interestingly, pediatric ultrasound, torsion and inflammation of testicle, acute abdomen, and many, many other things which are commonly seen scenarios in emergency. I'm really interested in everything here, and I'm sure that they're going to be of great benefit to everyone working in emergency. We are very glad to have, for the low-income countries, granting scholarship with very big, reaching up to 75% discount for those who are coming from the low-income countries if they deem interested in our program. And we are very open to help anyone who needs help. It's our pleasure, actually. Back again to the timetable, not to take much time. We will start now by Dr. Mona Surur and kindly Dr. Surgery to introduce Dr. Munasirur. I'm going to stop to share now, and then we go to our program tonight. Ready to listen to your questions? Please, again, drop your questions to Q&A section, and we'll come back to you. Thank you very much. The floor is yours, Dr. Surgery, to introduce first speaker of tonight.
Okay. Hi, everyone. Happy to introduce today to Dr. Mona Goma, lecturer of Emergency Medicine, Alexandria University, Egypt, Son School Egypt, chapter director, international instructor in FCCS of American Society of Critical Care Medicine, TCF, American Heart Association for BLS, ATLS, instructor, American College of Surgeons, coordinator for surgical emergency for master and doctor degrees, lecture in ECE, early clinical experience, and skill lab learning for Manchester students, Alexandria University.
Hi, by the name of the God, we'll start our talk about the point of care ultrasound in pediatric emergencies. Our objective to understand the diagnostic accuracy domains where POCUS is stand for in children, practical protocols and pitfalls, how to implement safe training, and questions and answers. Pediatric emergencies including a wide range of conditions that require immediate decisions making and immediate treatment and interventions. Most of the common presentations of the pediatric population in the emergency, such as respiratory distress, and it's also one of the common causes of arrest in pediatric population, so it's need a rapid decisions and rapid treatment. Abdominal pain with various GIT manifestations like diarrhea, constipation, red jelly stool, also high fever, seizures, head injuries, burn, poisoning, and dehydrations. So prompt recognitions and response are crucial for this, can be life-threatening in injuries. Why point of care ultrasound is preferred in pediatric emergencies rather than other investigations? Because it has a low cost, can done bedside, rapid, no radiation exposure for the children, help you to take a rapid and improve the procedures, increase injuries, and useful in low resources setting, and also the ability to perform a whole body scanning or whole body examinations without feeling of the radiation exposures. There is some point of care sound indications. I summarized the sensitivity and specificity from multiple studies. Let's start by the using of the lung ultrasound in the diagnosis of the pneumonia, which has a sensitivity 95% and specific 95% with a high diagnostic accuracy, and this demonstrated by a meta-analysis including 26 studies on over than 3,000 children. And their message is that the lung ultrasound is excellent to rule out pneumonia with better sensitivity than just X-ray, also, and it's radiations free. For the cardiac POC, the interceptions also having a high specificity up to 99% with a pediatric POCUS meta-analysis with a very high accuracy, and it's highly reliable when performed by a trained operator and excellent ED tools. In appendicitis, it's operator dependent, but by multiple studies, positive POCUS help to rule in, but negative does not exclude appendicitis. First in trauma patient or abdominal trauma in formative, but negative does not rule out the injury.
You have any problem, Dr. Mona, with the sounds?
Could you hear me, Dr. Ashraf?
We can hear you. Yeah.
Okay. Sorry for the. Okay. In assessment for dehydrations for IVC and the water ratio, also recommend useful to use its adjuncts only combined with the clinical estimations. Also can use in soft tissue as we will discuss later on with Dr. Omar. And cardiac POCUS, it's have sensitivity up to 59% and specific up to 90-80%. And it's great for rapid shock evaluations, but not a full echo replacement. And using also the ultrasound for vascular access guided, it's one first attempt success by 2 to 3 times. If you started by the lung ultrasound in the chest, it's a diagnostic for community-acquired pneumonia having a higher sensitivity than chest X-ray as recommended by many studies. Also useful for the diagnosis for pleural effusions, pneumothorax, and bronchiolitis assessment. Let us review the literatures for a systematic review published in 2024, systematic review and the meta-analysis of the accuracy of the lung ultrasound and chest radiography in diagnosing community-acquired pneumonia in children. This pooled the 30 diagnostic studies totaling more than 4,000 children. They found that lung ultrasound having a sensitivity 94%, specific having a sensitivity 89 and specificity 90.6%. In short, they recommend the lung ultrasound is highly sensitive and useful to rule out pneumonia at the bedside in the ER. For performing a lung ultrasound, we divided the chest according to the imaginary anatomical line, a parasternal line and the anteriorly axillary line and mid and posterior axillary line and the paravertebral line with a transverse line from the below the navel. So which these lines will divide each part of the chest into 6 quadrants. So it will in finally examinations of the right and lung in 12-point examination, starting by using the high frequency linear probe, moving from the top to the bottom and from sagittal orientations to transverse orientations. Let us discuss this case. 7 years old child presented with a and focal lung finding and respiratory distress. Ultrasound identified there is a left lower lobe pneumonia, so it helps us to make you rapid decisions and rapid interventions. We can observe this is a view at the collapse point, showing us losses of the mirror image and loss of the curtains with visualizations of the consolidations in the lower lobe of the left lung. In some cases, when the consolidations become on the periphery, we can demonstrate a shred sign, which is interruptions or shredding of the pleural line by the hypoechoic consolidations. And this is also a shred sign for the subpleural consolidations. We can demonstrate the hypoechoic shadow, the shredded pleural line and B line. Also, ultrasound is sensitive than the chest X-ray for detections of the pleural effusion. Chest X-ray, the least amount can be detected in a lateral decubitus is a 75 milliliters, but by ultrasound you can detect from 20 milliliters by the point of care ultrasound for the pleural effusions. We can demonstrate in the image there is anechoic shadow of the pleural effusions and absence of the mirror image and the spine sign, and here a part of the lung appear as a tongue sign. When we look for this video, you can observe the loss of the mirror image and the loss of the curtain sign, and also we can demonstrate the shadow of the fluid as an echoic shadow with the spine sign and a part of the lung as the tongue sign or jellyfish sign, which are diagnostic for the pleural effusions. If you talk about the point of care ultrasound in abdominal emergencies, according to this article published very recent in 2025, studying the book acute abdominal pain, practical scan for children presenting with acute abdominal pain, POCUS offer a valuable first-line imaging modality and also it's radiation free and can done and escalate when it's positive, and when it's negative you can observe or follow up or using another investigations according to the case. So using the point of care ultrasound can reduce the length of the stay in the ER and reduce the use of unnecessary imaging and radiation exposures for the children. For example, in acute appendicitis, POCUS can identify non-compressible appendix, periappendicular fluid, appendiculus, secondary signs like abscess formations. A recent pediatric meta-analysis showed both performance. Various uses POCUS to in when it's positive, but when it's negative, it does not exclude, but you need either observations or another investigations modality. Here is this example, ultrasound imaging in longitudinal and transverse orientations for the appendix. The first image labeled by letter A, showing acute appendicitis. We can observe the appendix is enlarged and it's a tubular blind-ended structures. And if we measure it, you will find the diameter is more than 6 to 7 millimeter diameter. This typical appearance suggesting uncomplicated acute appendicitis. In pictures labeled by B, we can observe that is the wall becoming irregular and hypoechoic, indicating ischemia and gangrene, and loss of the normal wall stratifications, and the lumen appearing to be more dilated, so reflecting more advanced inflammations. The third image, you can observe the appendiculus or feculus, which appear as a hyperechoic with a posterior acoustic shadow. And this is strong predictors for obstructions and increase the risk of perforations. The last image is for perforated appendix. You can observe the disruptions of the wall of the appendix with anechoic collections around the wall with periappendicular fat stranding, confirming the complicated appendicitis. One of the most common differential diagnoses between acute appendicitis in pediatric population is the mesenteric appendicitis. So you can easily using your ultrasound probe to differentiate between appendicitis and mesenteric adenitis. In a case of the mesenteric adenitis, you can demonstrate the multiple inflamed lymph node enlarged like this with the absence of a visibly enlarged blind-end structures of the appendix. Intussusception, one of the most common presentations of the pediatric population in the ER, it's occur when a segment of the bowel telescope into the other segment or into itself. It's a common cause of acute abdomen and one of the most common cause of intestinal obstruction in children. So, and has a significant complications such as bowel necrosis and bowel perforations. So, its time is important factors in the diagnosis and starting the treatment. The classical triad of the presentation, including abdominal pain, vomiting, presence of right upper quadrant mass, may be paired with a gross or occult bleeding on rectal examinations. POCUS has a high sensitivity and specificity for detection of intussusception, as well as a high negative predictive value. We can observe by two signs in the intussusception. One of the target sign when the inflamed bands of hyperechoic mucosa and relatively hypoechoic submucosa are visible. And the second sign is the pseudokidney sign. It's caused by the dragging of the fat-containing mesentery into the intussusceptions, giving the appearance of a small longitudinal axis of a small kidney. Also, children presented to the ER by trauma and by primary survey assessment, it has a good specificity for the free fluid, but lower sensitivity for solid organ injury. And also, positive FAST is actionable. You should take any decisions over this positive FAST, but if it's negative, it does not exclude the injury. You can observe your patient and you can repeat the e-FAST again, or you can recommend for other investigations if your patient is stable. e-FAST in adult is similar to the e-FAST in children. We're getting right upper quadrant view for assessment of the Morrison pouch and assessment of the inferior wall of the kidney and assessment for the collections between the liver and the diaphragm, and also assessment for presence or absence of a hemothorax, presence of a mirror image sign, and the curtain image and the curtain sign excludes the presence of a hemothorax. Also, the left upper quadrant space to assess the spleen-renal space and the tip of the spleen and the inferior wall of the kidney, as they must more exposed to the trauma. Also to assess the collections between the spleen and the diaphragm, and also assess the hemothorax on the left side by examine the mirror image sign and curtain sign, presence or absence of the spine sign. Then pelvic view, transverse and longitudinal actions for the pelvic collections, and subxiphoid view for the presence of the hemopericardiums and whether tamponading or not if it's present. And we have both long view, one on the right and one on the left, for detections of the pneumothorax by the absence of the lung sliding and by barcode sign on the M mode, and the sure sign is to finding the lung point. Here there is a video for positive first in right upper quadrant. You can notice, and this is a video for positive left upper quadrant. You can demonstrate the anechoic fluid collections between the spleen and the kidney. Also, ultrasound can be used for dehydrations and volume status assessment. IVC size and collapsibility are highly correlated with the volume determination and responsiveness to fluid. In setting of avolemia and normal right atrial pressure, IVC collapse during inspirations greater than 50%. When we have increased right atrial pressure, a dilated IVC with decreased collapsibility less than 50% and suggestive of hypovolemia will demonstrate a collapsed IVC. We can demonstrating the IVC while the patient is lying supine by placement of our transducer into the longitudinal positions. IVC examinations in the teenagers is similar to an adult. We examine the IVC and measure it about 3 centimeters from the right atrial junctions. But in infant, the IVC to the descending aorta ratio more accurate for volume estimation. So an alternative determination for volume status and responsiveness in pediatric patient utilize the IVC to descending aorta ratio. It has a sensitivity of 86%, specific 56%, and should therefore used in combination with the patient clinical history and clinical finding during your examinations. For visualizing the IVC, you use, as the adult, you use your curvilinear probe or phased array probe, transit longitudinally into the right, in the subxiphoid axis of the IVC entering into the right atrium. And we take a 3 measurement for the maximal diameters of the IVC and getting the sagittal view of the aorta and measuring the diameter of the aorta 1 centimeter proximal to the celiac trunk, and also measure it 3 times and take the average for the 3 measurement of the maximum diameter of the IVC and the 3 measurement for the aorta, and then take the mean value, then calculate the IVC to aorta ratio. We have a normal IVC to aorta ratio for each age group, but roughly we can say that the IVC to aorta ratio approximately 1 suggesting euvolemia, when this ratio is less than 0.8 suggesting of intravascular depletion. One of the most common use of POCUS is sound echo. POCUS echo is similar between adult and pediatrics. There is no major difference, but the pediatric examination sometimes challenging to get the certain window due to smaller intercostal space and increasing the rib shadow. Also, the faster heart rates in a younger populations, they have a higher heart rates than adult, so it may be challenging for visualization of the intracardiac structures. Point of care ultrasound echo can help you to show physiological and hemodynamic information such as pericardial effusions, altered systolic functions, but evidence-based guideline does not recommend using POCUS as a screening tool for diagnosing congenital heart defects in newborn children. No, you must use formal echo. Let us run through this case. A 11-year-old male was admitted to the pediatric inpatient unit for treatment of pneumonia. After being in the hospital for 6 days without improvement of the pneumonia, the patient acutely developed progressively worsening chest pain, shortness of breath, and diaphoresis. The pediatric ICU physicians consulted overnight for the evaluation of the patient. He noticed that the patient looks ill in sitting position using his accessory mask. He was afebrile, tachypneic, respiratory 110/70, with a saturations 94% on a simple face mask. No ECG was available. The first diagnosis, all we think when we run through this history, this is the progressions of the already existing pneumonia. But while they evaluating the child, they perform a long ultrasound for following for the pneumonia, but they found that the normal lung artifact obliterated by large anechoic structures. So they perform a focus cardiac POCUS. They found that the heart accepted a swinging movement with a large effusions with a diastolic right ventricular collapse, and visualizing this is the video of the patient. showing the heart is completely, you cannot identify the heart chambers due to the compressions of the heart by the surrounding pericardial effusions. The heart looked like a piece of tissue swinging in the fluid, and by assessing the IVC, we found a plethoric IVC with no collapsibility. So they diagnosed a cardiac tamponade and performing a pericardiocentesis for the child, and the child much getting improved very shortly after doing pericardiocentesis. So another diagnosis, it was a way of your mind. Also, we can use the point of care ultrasound for guiding procedures like vascular access, lumbar puncture, thoracentesis, and paracentesis, reduce the complication, especially of the central access and other procedures. One of the most preferable use for me for using the point of care ultrasound in airway. Okay, we have multiple uses and multiple indications for using point of care ultrasound in airway, but the mission is estimations of the size of the endotracheal tube by getting the airway view at the level of the cricoid cartilage, because it's the narrowest subglottic part of the airway, and measuring the diameter of the air colon, then put this diameter in equation, dividing this diameter by 1.3 for uncuffed tube and for cuffed tube, divided this measurement by 1.7. And the multiple studies revealed that the POCUS size estimations by the ultrasound is more accurate than the used equation depending on the child weight. Also, we have another use, like use of the ultrasound in soft tissue and the musculoskeletal, as with Dr. Omar discussed later on, and also in ocular emergency, especially when you are suspecting increased intracranial pressure in a child, hemodynamically unstable, you cannot transfer it for doing CT, you can use the optic nerve sheath diameter, and it's highly correlated with the increasing of the intracranial pressure. The uses of the point of care ultrasound in pediatric emergencies, really very wide range of indications, very wide range of uses. You can use your point of care ultrasound in examinations of every system. You can guide you for the immediate rapid diagnosis, and once you reach immediate diagnosis, so you will take a rapid decisions for immediate treatment, and it will get reflective positive impact on your patients. So to do point of care ultrasound and take a decisions on it, you must train well. So competency-based training, hands-on supervised scan, imaging, achieving quality assurance, use minimum scan numbers according to image review, and practice much more as you can. All this help you to mastering the point of care ultrasound, so you can achieve the view rapidly, and can reach detecting the pathology also rapidly, and help you to helping our patients. Thank you for your time and for your attentions. We will discuss the later on. To take home masomia, target abdominal diagnosis like intussusceptions and appendicitis, and procedural guidance. It often speed decisions and reduce radiation exposures. For appendicitis and trauma, don't forget positive POCUS is helpful, but negative does not exclude. Combine with clinical judgment and further imaging as needed. Training, and imaging achieving are essential. Accuracy is also operator dependent. Thank you for your time and for your attention.
Thank you very much, Dr. Amona. Very, very nice presentation.
Thank you, Dr. Ashraf.
Incorporated everything in one lecture. Every part of your lecture can be a lecture. Thank you very much.
Yes,
Dr.
thank you.
Salah,
Thank you.
to introduce Dr. Omar, please.
Well, thank you, Dr. Salah, for your nice introduction. Dear Dr. Ashraf, Dr. Mona, and our moderators, you are welcome also, and thank you for having me. I would like to especially thank Dr. Mona, because it is such an extensive topic that could be concentrated in a very, very short time. So thank you too.
Thank you,
Well,
Trump.
I'm Dr. Marja Radat, and it's my pleasure to be with all of you in this webinar today. I'm going to talk about the utility of POCUS in soft tissue infections and injuries. And before I start, this is my disclaimer. So let's begin. So many patients come to the ED with complaints related to soft tissue problems, such as infections, injuries, and abnormal masses. As the ultrasound is readily available in point of care setting and also in low source settings, so it's now is the preferred study imaging regarding the soft tissue problem. So most of patients came to the ED with soft tissue abnormalities such as infections like cellulitis, abscess, myositis, fasciitis, also foreign bodies and traumatic injuries like strains, sprains, and hematoma. The key advantage of the ultrasound in soft tissue is as follows. First of all, it is applicable at the bedside. So we can use it in the ED clinic or in the ICU, I'm sorry. Also, it gives a real-time assessment, especially when we use the Doppler feature to assess the compressibility and the vascularity of the soft tissue. It helps us to make the differential between the problems regarding the soft tissue. Also, it helps us to define the anatomy, which is so important to make the differential. So it localizes the infection, whether it's restricted just to the skin or it's extended to the subcutaneous tissue or to fascia or muscle. Another important thing regarding the ultrasound in soft tissue is it guides the intervention. So as soon as we make the differential between a cellulitis and abscess, we can use the ultrasound guided aspiration, or as soon as we set a diagnosis of necrotizing fasciitis, so we can send the patient to the operation room as soon as possible. And also, it's safe for all because it's no radiation, the ultrasound. So it's really, really applicable in soft tissue problems. Let's first talk about the role of POCUS in soft tissue infections. And I would like to talk about the probe selection. We prefer the linear, the superficial high frequency probe, which is between 7 to 12 megahertz, to view the superficial tissue or the soft tissues. But once, if it's unavailable, we may use a lower frequency linear probe. And if that is not available, then we have to use the curvilinear probe. And that's it. And what about the scanning technique? It is a little bit different from the standard ultrasonography technique because the soft tissue scanning requires a stable grip. So we tend to rest our ulnar aspect of our hand or the small finger on the patient to achieve a fine and controlled movements. Also, we start to scan from normal to abnormal. This is to set a baseline of the sonoanatomy of the tissue. Then we slide back to the pathologic or the abnormal tissue. Also, we always scan in two planes, the longitudinal and the transverse. This helps us to identify the surrounding tissue and the problems more accurately. And finally, we compare it bilaterally. I mean, we use the contralateral side as a reference to see what's normal for that patient, because it really gets different from patient to patient. And just a small mem, liberal use of gel is encouraged because it requires the soft tissue scanning technique, requires extensive use of gel. So let's talk about the sonographic anatomy of a soft tissue. Here, at first, we see the hyperechoic line, which is the skin. It consists of the epidermis and dermis, but we can't distinguish between them sonographically. And below of it, we will see a hypoechoic tissue, which is the subcutaneous tissue. The hypoechogenicity comes from the fat lobules in the subcutaneous tissue, and we see hyperechoic linear appearances or views. They are the connective tissues in the subcutaneous tissue. When we go deeper, we will find the hyperechoic thin line, which is the fascia. It surrounds the muscles, and below of them we will see the hypoechoic area, which is the muscles. They include the hyperechoic striations, which are the muscle fibers and perimysium. This is another view for a normal sonographic anatomy for soft tissue. So let's talk about our first sonopathology, which is the cellulitis. It is actually a diffuse non-suppurative infection of the skin and subcutaneous tissue. The sonographic appearance of cellulitis differs depending on the stage and the severity. So in early cellulitis, there will be a swelling which leads to increasing the echogenicity of the subcutaneous tissue. So the normally hypoechoic fat will become more hyperechoic, as we see in this view. And let's look to this video. We will see that the well-defined subcutaneous texture is now disrupted, and there is increased in hyperechogenicity in the view, suggesting an early sign of cellulitis. Once the cellulitis gets worse, the advanced cellulitis and the signs will appear. So when the fluid increases in the subcutaneous tissue, the fat lobules will become more hyperechoic, and they will be separated with the hypoechoic fluid-filled septa. As we see in this video, we see it's called the cobblestone sign, which we see here the hypoechoic lines and the hyperechoic fat lobules. But watch out, the cobblestone sign, is not a specific sign for cellulitis, as it can be seen in systemic illnesses, and this is like chronic heart failure. So we always scan the bilateral and the contralateral side. As we see in this view, this is the normal side on the left leg. And in the right leg, we see well-defined advanced cellulitis with cobblestone finding. Also, we can use the Doppler feature of the device, and we will see an increased vascularity due to the hyperemia in the affected area, finding suggestive of the advanced cellulitis. Let's move now to the abscess. They are spherical or oblong structures. They are largely anechoic or hypoechoic, but they often contain hyperechoic debris or pus. Because of the nature of the anechoic fluid in the abscess, we usually find the classical finding, the posterior acoustic enhancement behind the abscess. So we will see the hyperechogenicity below the posterior wall of the abscess. From the other side, the walls and the margins of the abscess are not well defined. They are thick and irregular. But there is something that will help us to distinguish between cellulitis and abscess. It is the swish sign. So when we apply a gentle compression with the probe on the abscess or on the affected tissue, we will see that the contents of the abscess will swirl or will move back and forth. This sign highly suggestive of abscess. And if we use the Doppler feature, we will see the halo effect, which means the avascular, the abscess or the pus, the debris inside the abscess is avascular, However, the wall and the surrounding tissue of the abscess will be highly vascular, and this also help us to detect the margins of the abscess and to set the diagnosis of abscess to distinguish between the cellulitis and abscess. So it's important to distinguish between these two entities because the management of the patient is will be widely different, especially in abscess, as we usually tend to make aspiration or incision and drainage for the abscess. The other sonopathology is the necrotizing fasciitis. Well, it is the infection of the subcutaneous tissue, the fascia, and the muscle. So we will find sonographically at first a fascial thickening and fluid. What I mean with that is that this is the fascia, and there will be and must be a supra and subfacial fluid. It's called this appearance or this view, it's called the dirty fascia sign. Once the fasciitis gets worse, the gas foci or the gas artifacts will appear and they will cause the dirty shadowing, which means the hyperechoic foci posterior to the gas. It is a kind of ring down artifact and called the dirty shadowing. As we see in these examples, the hyperechoic ducts or foci are the gas, and below of them we see the ring down artifacts. And this is all of those views suggestive of the necrotizing fasciitis. Once we set the diagnosis of it, the patient will find himself in the operation room. So it's important. So it's important to distinguish the fascia to make the differential between the cellulitis or erysipelas and the necrotizing fasciitis. So let's see this example. We see a suprafacial fluid, but the deep fascia is intact and there is no fluid below it. So the diagnosis in this for this patient is more suggestive to be cellulitis. And once the this patient was diagnosed as necrotizing fasciitis at first, and once he brought to the operation room, they found that he was just have a complicated cellulitis. So it's important to distinguish the fascia and the subfacial fluid to set a diagnosis of necrotizing fasciitis, especially in the early phases. But once it gets worse, we actually depend on the dirty shadowing or the gas appearance, which is diagnostic for the fasciitis. And the other one is the pneumomyositis, which is the infection of the secretum muscle, and it is more often complicated with abscess. As all we know, this is the normal texture of the muscle, which is a fine striated pattern. It's a longitudinal view, and this is a transverse view of a normal muscle. Once the pyomyositis develops, we will see an edema in the muscle. So it will be more swollen, and which will make the muscle texture more hypoechoic, as we see in this example. And once the pyomyositis gets worse, we will find definitely an abscess with debris or pus inside the muscle, as in this example. Now let's move to talk about foreign bodies. Foreign bodies can play the role of needles to infections. So it can be complicated with cellulitis, abscess, or the hypervascular tissue, the granulation tissue, if they not detected in the early phases. However, the ultrasound is the choice, the first choice to detect the foreign bodies, because the foreign bodies usually are hyperechoic, as we see in this example. And it depends on the composition and the shape of the foreign body. they are often give or produce acoustic shadowing. We see it more prominently in wood, glass, and plastic, as they tend to produce acoustic shadowing. But in metals, metal foreign objects or bodies can produce shadowing and reverberation or comet tail or ring down artifacts. As we see, here is the acoustic shadowing that caused by a foreign body. And the next example is the comet tail or the ring down artifact, which suggests the evidence of a metal foreign body. And this is the reverberation artifact. We see here a longitudinal foreign body that produce the reverberation artifacts that are very similar to the A lines in the lung ultrasonography. However, in this view, we see the hyperechogenic or hyperechoic dots. This is the sand. When it's enter the soft tissue, it will produce a hyperechoic dots that may be a little bit different from the previous examples regarding the foreign body. It is important to use both planes, the longitudinal and transverse, to once we are scanning for foreign bodies. This is important to distinguish the surrounding tissue and whether there is a vascular tissue near to the foreign body. And the other aspect is to distinguish or estimate the true dimensions of the foreign body. So we use just the longitudinal and the transverse axis views, and just be careful not to use the oblique views, as they will underestimate the length or the dimension of the foreign body. Also, the ultrasound helps us to extract the foreign bodies, as in this example. This is the hyperechoic longitudinal foreign body, and this is the forceps. And now I here extract catch the foreign body and grab it back outside the soft tissue. So ultrasound is the first choice to scan for foreign bodies in the soft tissues. Now let's talk briefly about the role of POCUS in soft tissue injuries. And first, I will talk about tendon ruptures. As we see in this view, the tendons are linear, organized, regular fibrillar patterns that connect the muscles to the insertion site on the buns. But once they get ruptured, we will find a discontinuity or an anechoic or hypoechoic defect in the tendon. So we can divide the tendon ruptures to partial tear and the complete tear. In partial tear, we will see a focal defect, but in the complete tear, we will see a full thickness discontinuity. As in this example, this is the patellar tendon, and this was also the patellar tendon. It's a normal view of the patellar tendon. And this is a full thickness or complete tear of the patellar tendon. You see the complete discontinuity, and you see the torn edge of the tendon, and you see here the hypoechoic area which filled with fluid, suggestive of hematoma. Let's see another example. This is the arches, which we can see it here as a linear and straightforward tendon, and once it gets disrupted, as in this example, you see that it has a torn edge, and there is a hypoechoic fluid suggestive of hematoma, and you see here the discontinuity of the tendon, suggestive of complete tendon rupture. Also in this exam, which is more comprehensive than the previous one, this also suggests the complete rupture or tear of the tendon, as we see. Let's move briefly to talk about muscle strains. Usually it's graded to 4 grades, grade 0 or grade 1 and grade 2 and 3. In grade 1, we know that the normal texture of the muscle is a little bit hypoechoic when it compared with the soft tissue, subcutaneous soft tissue. But once a trauma happens to a muscle, we may see, as in this example, that an edema or fluid collection in the muscle. This will increase the hypoechogenicity of the muscle, but we can see here clearly that the striated pattern of the muscle here is not disrupted. It can be selected. So this will be diagnosed as grade 1 muscle strain. But in this example, we see a torn edge of a muscle. So this suggests a partial tear, and we see here a little bit hypoechoic enhancements suggestive of fluid or hematoma in the muscle texture. This tornage and the evidence of the hypoechogenicity here suggests the partial tear, which is the grade 2 muscle strain. However, in grade 3, as we talk in the tendon ruptures, we will see the previous findings in grade 1 and 2 add to this a complete tear of the tendon of that muscle, which will be identified as a grade 3 rupture. That's all I can talk about muscle strains for now. Finally, I would like to introduce a specific lesion. It's the Morel-Lavallée lesion, which is a closed internal degloving injury due to shearing trauma. It leads to a fluid-filled cavity between the subcutaneous tissue and the fascia, and classically found on the lateral thigh, hip, and knee. It is so specific because it has an extensive fluid collections. Its margins is well defined, and it may include septations that are the globules, as we see in this example. There's the skin, and there's the subcutaneous tissue, and there's the fascia. And we see here a fluid collection between the subcutaneous tissue and the fascia. However, in some examples, we can encounter the fatty globules that are swimming inside this fluid-filled area. And usually, we tend to aspirate these kind of lesions. Once it gets failed, the saturation will be the second choice to treat these kind of lesions. For now, that's all I can have to talk for today. And thank you for having me. And I'm looking forward to answer all of your questions. And thank you.
Thank you very much, Dr. Omar. Nice presentation. Dr. Surgery, if you have question to Dr. Mona, and Dr. Salah, if you catch any question to Dr. Omar.
Yeah, I have 3 questions.
Go ahead.
First question, I want to ask Dr. Omar.
Go ahead.
Yeah, thank you for this lecture. It's first question, I want to ask about the difference between the linear probe or curvilinear probe to use in soft tissue in pediatric. It's not easy.
According to the presentations of the patient, abdominal pain, you by the clinical finding and by the complaint and your finding in the examination. If you are suspecting for internal obstructions, so according to the age of the patient, you can search about the signs of intussusceptions. Or if in case having a pain on the right side, for example, or a pain on the right iliac fossa, localized pain, so you are suspecting appendicitis, so you're searching for the acute appendicitis. But you are not doing a formal ultrasound abdomen pelvis for examinations, all the abdomens for the abdominal pain. It's not a POCUS ultrasound, it's a formal ultrasound. But in a POCUS ultrasound, we are to the point. You have questions in your mind and wanted to search for your answers. So according to the clinical presentations and the finding in your examinations, you can couple the use for the POCUS as a part of your examination or a part of your investigations to more support your opinion or exclude this differential diagnosis from your mind.
Very good.
Thank you.
Thank you, Mona. Actually, Dr. Mona, you make my life easier, because since I started the journey of point-of-care ultrasound, I was wondering if the exam in pediatric age group is different than the adult. And I've been asked this question several times, but because I didn't go through the evidence or the material of point of care in pediatric, I couldn't answer this question clearly, but you answered it now, that there is no big difference in the application of point of care ultrasound in different age groups. Adult are the same like in pediatric. So pleural effusion, pneumothorax, consolidation, collapse, the heart the same, the abdomen the same, vessels the same. So if you just know the basic knowledge and you apply this basic knowledge bedside, it doesn't really make difference. Yes, there are some little differences that are not usually in the time of acute illness. So acutely ill patients, trauma or non-trauma, when they present to ED, they are the same. So if they positive fast, the same present in adult and as in pediatric. And same group, even you use them. Yeah, we are asking, it's not commonly available to have a smaller probe for pediatric age group, but hopefully in the near future, we see a small designed probes for the pediatric age. So again, thank you, Dr. Mona, for this very nice presentation. And Omar,
Dr. Ashraf.
Really, I was expecting to learn from everyone's tonight presentation. I did. It was very nice presentation of how the soft tissue infections appears in different levels. When it's coming to superficial cellulitis, when it goes to deep fascia, necrotizing, when it involves the muscle, when you differentiate abscess from non-abscess. It was a great presentation. And these, ladies and gentlemen, are examples of what you're gonna see in the module of emergency. There are really, really a lot of interesting topics to be taught in the advanced emergency module. Again, the module is planned to start on January 30, plus minus a week. So please visit the wiccam.org and register your interest in this important module. And for those who are engaged with us in the common pathway, we're about to adjourn, and the exam is coming late December. Maybe the last 2 weeks of December will be the final exit exam of the common pathway module. If any other questions or comment from the panel? We have a very interesting another webinar coming on December 3. It's for the critical care section, where I'm going to talk about tips of bedside exam in echocardiography for critical ill patients. And Michael Lanspa from United States will speak about pericardial effusion case presentation tips for bedside management. And Walid Al-Habashi from UK will speak about the basic eco-views tips to improve the image acquisition. And we have Dr. Wissam Ibrahim to be asked about his week for our fellows. Dr. Wissam Ibrahim presented paracentesis and fluorosynthesis. So make your agenda to attend, register first. Nurhan put a very important information in the chat group about the different sites that you might be interested to visit. So please have a look on the chat group to see this important announcement. For those who asked about the certificate of attendance, it will be available, it will be sent to your email in a week time, if I'm not mistaken, this Nurhan and Habiba. And for those who are asking about materials for ultrasound in acute abdominal emergencies, we ask kindly Dr. Amuna to, if you have a minute and you have it available, any of the interesting paper for acute abdomen, if you can put it in the chat group or later on the WhatsApp groups that we have. And easily to serve.
Okay, I can send it later on the WhatsApp group.
Very good. Thank you very much, Dr. Amuna.
Welcome,
I went through everything in the Q&A. Floor is yours for anyone who wants to comment from the respected panel group. You want to add anything, Dr. Salah?
No, I want to thank all about this lectures. Yeah, it's not easy. It's difficult to resuscitate pediatric patient in emergency department by ultrasound. To use point of care in pediatric patient in patient came in emergency department, ill patient, or like a foreign body aspiration or foreign body swallowed, to differentiate it. We don't have a time to send patient to do fluoroscopy or CT scan. It's just.
Thank you very much,
Yeah.
Dr. Salah. And again, we are happy to grant anyone who is willing to be granted from the low-income countries. The main purpose of these activities is to teach those who are interested. If you want to add anything, Dr. Surgery, and actually we are very, very proud to have you tonight.
Thanks for this invitation. I look forward to keep working with this great group and grow together. Thank you very much.
Thank you very much. I would like to thank ICOM group, Habiba, Nurhan, and Ala for this very nice hosting tonight. Thank you very much again, everyone. Thanks for all who attended this webinar. It's going to be the record of this webinar will be available very soon. Hopefully, Habiba will put it in the groups. And we have a lot of social media pathways to reach us. And we are welcoming your questions and thoughts at any time. Thank you very much again. See you in the next webinar. Bye-bye.
Thank you, Dr. Ashraf. Bye-bye.
Bye-bye. Thank you.
مع السلامة.
Bye-bye.
Bye.